Hey Fix listeners, I want to take a minute to give you all an update on our DPO, Smile Now Dental Group. In case you haven't heard, we've been opening up locations all across the country for doctors just like yourselves. We started several offices this year to show proof of concept, and it's been off to the races ever since. So if you're looking for an equitable partnership opportunity where you can have a profitable business that supports you doing full arch, I'd love to hear from you. We're looking to add several locations in the next year and want to offer the training and support necessary to make one of those yours. If you'd like to learn more, you can go ahead and hit me up on Instagram at Dr. Tyler J. Tolbert, or shoot me an email at tyler@smilenowdentalgroup.com and say hey. Now, without further ado, let's get back to the show. My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Poppy,
And you're listening to the Fix Podcast.
your source for all things implant dentistry.
Hello, and welcome back to the Fix Podcast. We have a special guest on today, though he's becoming somewhat of a regular. Today we have on Dr. Clark Damon, who has graced us with his time. And today we're going to be doing something that looks like it could be a recurring segment for us. So for those of you who have taken his course down in Texas at the Texas Implant Institute, you get to be a part of the Tribe. It's a WhatsApp group with all of the alums from Clark's courses. And in there, you get to have these really candid conversations with all the other alums doing Fix Full Arch, the good, the bad, the ugly. We share cases in there, and Clark is very on top of all the messages in there, giving feedback, giving recommendations, sharing his own cases, whether they go to plan or not. It's been a really valuable community. So we got to thinking, I think it was actually Clark's suggestion that we come on here regularly and talk about some of these topics. And so we really appreciate him taking out the time, and welcome back to the show, Clark.
Yeah. Well, thanks. Well, and, I also wanted, to, interview you guys and actually let y'all, be a part of, what the tribe that you're creating with your,
Sure. Yeah.
with your podcast and maybe have something that's a little more laid back and, just kind of talking about like, what's going on, where are people headed for CE, just kind of just a little more, more fluff, kind of what's working, how your practices are moving, and just, there's always these seasons in a full arch practice. And, the seasons can be, whenever you started, or it could literally be within, the quarters of the year. I think typically, the first half of the year, full arch practices are busier than the latter half. And, marketing is always something that changes, and I think that's everybody's, vein and, or bane of existence. And, so it's kind of interesting to see what's working, just kind of that kind of stuff. So.
Yeah, absolutely. We'd love to get some questions for you too. We're usually on the giving end. So being on the receiving will be nice.
Absolutely. So, but yeah, I did want to, and you're more than welcome to flip the script on us, and be the first time that I think either of us have ever been interviewed on our show. So I'm more than welcome for that. But yeah, so I did put together just a few topics, kind of going back through the tribe conversations all the way back to, I think when we first joined was back in January of this year, and there was a really interesting topic that came up, and I think it actually came up around the time that Soren had a case like this come through his clinic, where you have a patient that, let's say they have a high smile line. They may not even have a particularly high smile line, but what you deal with is you have pneumatization of the sinuses that goes so far to the point where you're trying to do your alveo and raise where that transition line is going to end up being, but you're out of runway. You don't have enough sinus bone to take away. So you've got these gums that are visible, and there's not any foreseeable way to do that simply with reduction like we normally do. And so in the group, you shared a case where you had done some sinus crushing. So basically upping the sinus floor, doing some grafting, and sort of raising that platform. So I was hoping you can kind of walk us through, indications for that, some issues that can come about, possibly some alternatives for cases that look like that, because every so often these do come through our door, and that's not a simple thing to treat.
Right. Yeah. So I think, the first thing is, understand your limitations, right? And know when to refer. Really, now there's a lot of clinicians, even myself, I'll go into people's offices in Texas and I even recently got an Oklahoma license, and
nice.
go into people's offices and help them out on more complex cases. So one issue that clinicians have is maybe they can do the lower arch and it's simple, but the upper may be, more difficult. And so actually bringing somebody in is so much easier. You can learn so much from that clinician coming into your office to treat your patient, versus just referring them out. Like if you refer the patient out, which is obviously can be the best thing for the patient, you miss out on that educational opportunity. And so, consider these options. I think Juan Gonzalez can come in and, he kind of flies around. I think the difference is a little bit limited to, can the clinician actually touch the patient if they have a license or not, right? So, that's something to take into consideration. But, hit me up if you're in Texas or Oklahoma and you want me to come do a case and you really want to learn. I'll come in. Let's get an anesthesiologist, knock them out. So, anyways, long story short is, I just think that that's a problem. I think too many clinicians are taking on cases that they really shouldn't be doing. Right? I think there's a big driver and a big push for revenue, top line. But when you push a case to be a standard that is not a standard, that needs to be done patsy, you're going to have, problems. And these problems will come home to roost, fairly quickly, with temps breaking, not being able to manage a smile line. So on a case where, the sinus, hangs inferiorly to the reduction plane, clinicians are going to have, they need to, one, identify it, and it can be a difficult thing to identify. Two, the clinicians, there's no way around it. You can't say, oh, we'll put a flange on it. You can't say, oh, well, we'll just have a shortened bridge in that case, because then it's going to be, a first premolar, $20,000, $25,000 implant bridge. So again, the patient's going to be unhappy. So clinicians typically have two options when dealing with this. One, you have to do something. So not doing anything is not an option. So option one is doing pre-surgical grafting, or pre-arch surgery grafting, and that is a very viable alternative. And on certain cases, we can do a sinus crush intraoperatively, and then that way the patient can have one surgery. Now, so what are the indications of a sinus crush? I think number one, the patient needs to be edentulous. Trying to do a sinus crush when patients have teeth is going to be, is going to be difficult. Oftentimes, and why, right? It is likely that you're going to have some type of communication. You're going to have, the sinuses are going to be pneumatized. The roots are going to be into the sinus. So oftentimes we're going to have several tears there. So I would say to do a sinus crush, indication would be edentulous.
Now, does that mean fully edentulous, or just edentulous in the areas where you would be looking to do the crush, so you don't have all that anatomy?
I guess that's a good point, right? They could be partially edentulous, and as long as they're edentulous in the area that we're crushing. Okay. But again, we're talking pneumatized sinuses. Yeah. So oftentimes, if there's a canine, if they're edentulous, maybe they only have the front 6 teeth. Well, having a canine may really be pushing it. Mm-hmm. So, always do what's predictable in your hands. So if doing a sinus lift is more predictable for you, that as long as you can nail it, and then that way you can come back and whenever you whenever you do your alveolar reduction, now you have sinus grafted material there. and you don't have to worry about a low-hanging membrane, and you don't have to worry about crushing it.
I want to quickly go back real quick to what you were talking about earlier about taking these cases on. And one thing I want to mention for everybody listening to this is if you take on, like Clark was saying, a case that should be patsy, and you do it for a certain price, you're not only, putting the patient in the situation where they might need another surgery in the future with like a zygo or something like that, but a lot of times you should just keep in mind as well that most of these patients that are coming to your office, at least most doctors that I know, they're charging a set fee for the whole surgery. So if you do that surgery and later it needs to end up being patsy, just remember that you're probably going to be the one fronting the cost for the second anesthesia, for another provider coming in to do zygos, and potentially someone coming in to do pterygoids. So yes, like these cases in particular, combination syndrome, Kelly syndrome, zygo cases, maybe pushing the envelope too far on palatal approach. If you start that case thinking, okay, yeah, great, like I'm gonna test out these different implants that I know, and then you might end up in a situation where you're paying out $10,000 for another anesthesia bill and another provider to come into the office by not referring that or bringing someone into your office right off the bat. Sorry, Clark, from getting aside from the crushing sinus thing. I just wanted to quickly mention that because I think that's a really important point. And when I first was like getting into like some of the more advanced implants, it happened to me one or two times where we ended up having to pay for another provider to come in to do zygos because I took on like a case. The cases that happened to me, they worked out. They were just an implant failed, and I needed a zygomatic implant. But just something to think about before taking on these challenging cases.
Yeah, it's always better to do things right the first time. And the cost of bringing a provider in when done the first time, you can still make a fair amount of money on that. It's just when you've already lost your afternoon the first go, mm-hmm. and then now you have a second anesthesia bill, you have a second prosthesis bill, second lab bill, second implant bill. Now you have a provider bill, and then, so not only are you not making money, but then now the patient's like, oh gosh, you had to have somebody else come fix it, versus, hey, I know where to go. This guy's really nice, and he's hooked me up with some other guy that can come in and take care of me. That's like a win-win-win.
You're a quarterback in that situation. Looks good.
Yeah,
for sure.
Yeah,
and never, don't feel bad telling your patient like, hey, I can do traditional all-on-4, maybe with pterygoids, very, very well, but your case happens to be one that needs a little bit more advanced implants for that. Luckily, I am good friends with some of the, if whatever circle you're in, but I'm good friends with some of the best implant surgeons in the United States, and I can have them come and piggyback me on this case so you get the best possible treatment. And patients aren't going to look at you poorly for doing that. You're providing them support and ensuring that they get really good care in your office.
And I do have a question about that too, Clark. So, you are, offering to others that are in Texas or Oklahoma, your services. If someone, books you to come out for, placing a zygo, what have you, obviously they're not comfortable doing it themselves, well, they're probably not going to be feeling very comfortable dealing with a zygo complication should that happen down the road. Right. So is that something that, whenever you have an agreement with somebody like, hey, I'm going to come out and help you out with this, zygo case, would you also be available to come out as well if there's any issues with that? Do you want to be there for follow-up? What does that kind of look like? Just to kind of paint a picture of, if I'm going to bring someone into my office, what can I expect if there's ever some issues?
Yeah. I mean, as you guys know, right? Like when you start doing more all on X cases, you get more all on X cases. Yeah. And it's not going to be, you're not going to have the one time that you need to bring an advanced provider in, right? Like these advanced cases show up on a relative frequent basis, right? Yeah. So
Sure.
What I try to do with, the current offices, one of my offices that I go to in Houston, I'm there once a month. Another office, that I'll go to in Oklahoma, I'm there once a quarter. Right. So, there's a regular cadence on
Okay.
that. And
Yeah.
so, oftentimes if there's some issue, you know, but going back, like, I mean, I really try to educate these patients. Like, hey, we did zygos. Do not use a water pick on your zygo. Sinus precautions for the first, 3 weeks. Don't get on an airplane. Most post-operative complications with a zygomatic are going to occur, a month, maybe 2 to 3 months down the road, right? So then, your cadence is kind of already there.
Sure.
And
Okay.
then also when you think with an open mind about that cadence, then now you're going to feel comfortable selling more cases, right? Like, think back when you guys had sold, maybe under 75 arches. I'm sure there were some cases where you're like, yeah, I can do this. In the back of your mind, you're like, nope, don't do it. Don't do it. Don't do it. Right. But if you have somebody coming in on a regular basis, boom, Mrs. Jones, we can do this for you. We're going to put that on Dr. X's schedule. He's going to be here in 2.5 months. No big deal. Whatever. We're going to, by the time we, send off your medical consults, your EKG, your labs, we get your teeth design, smile design, you're only going to wait a couple of weeks. I mean, you can just kind of create a song and dance. So
Sure.
certain things to just kind of, think through. That is the one challenge is if a patient has a larger postoperative problem, we don't want to abandon the patient. And so
Yeah.
the clinician does need to, take that into consideration. So whether or not you meet the patient halfway, patient comes to your office, you go to theirs, vice versa, that sort of thing.
Yeah. So I do want to go back to the sinus crushing just a little bit. So when it comes to the intraoperative sinus crush, what does that look like? What's the instrumentation? How are you thinking through that process?
And what complications have you seen?
Yeah, that's great too. Yeah.
Yeah. So, all right. So we'll just kind of go back in indications on that. Again, for a sinus crush, I want it to be edentulous or at least edentulous in the site that we're going to be crushing. The technique, you want to use like a number 8 diamond burr, and you want to score that 360 degrees around where you're going to tap in. And obviously these are it's a sinus. It's a large sinus. So just picture you're going to want to crush an area that's probably the size of your thumb. Okay. So you want to make a really big elliptical scoring of the bone, and especially the palatal bone. So if we're going to be dealing with the palate, we're going to want to reflect all the way down to the horizontal portion of our palate. We're going to want a large palatal reflection, a large buccal reflection, and we're going to do a 360 degrees scoring, roughly the size of your thumb, concentrically around the sinus that you wish to crush. After you've scored it, then you can take your osteotome. You take the back end of the osteotome, right? Like just picture the Norris 3.0 osteotome, okay? You don't want to choose the pointy one, but you want to choose the one that has the blunt tip. Well, you're going to use it in reverse, right? So you're going to take the fat end of the handle, and you're going to hammer onto the blunt tip of that osteotome. And so that's going to crack and fracture in that sinus. And then you just continue to push it up and push it up. Then you have to make sure that you've gotten it up beyond your occlusal reduction plane. Well, so how do we know that? Well, probably need an MUA guide And with your MUA guide, you have the teeth there, and you need to measure up, 12, 13, 14 millimeters. I would measure up 14. I like 14. Make sure that the bone is reduced beyond that. And so that way we can establish our restorative space, emergence profile, and hide our transition line. So,
Okay.
Really, so to date, I've done 3,000 arches. And the number of arches that we've done sinus crushes on is 0.1%. So I've only treated 3 cases with the sinus crush. Now, there's a lot of cases out there. I mean, I think probably both of you guys have seen cases where, we need to do something here. So it is prevalent. Yeah. What's been interesting though is the patients haven't had the money, the ones that have needed the sinus crushes. So they actually, they haven't moved forward with treatment, which has been interesting. So that's why I only have literally three out of 3,000 arches.
Yeah.
So, complications, none of my cases had complications because again, it just kind of goes back to case selection, and they didn't have teeth, right? So again, I'm going to take out variables that I can't manage, right? So if I get a large fracture of the alveolus, if I get a large sinus perforation, then now complications go up, right? You can get the sinus to be infected and all that sort of stuff. Another part of my technique is I'm not utilizing particulate graft. So we fracture the sinus in, the sinus stays attached to the bone and all of that periosteum and all that blood supply, and it goes in. And maybe I'll put 1 or 2 pieces of collar tape, no more. And that helps hold up the material. It establishes a really good blood clot. And then you can utilize a nice just collagen membrane over that to help seal it off. And, I'll push the sinus up, all the way kind of front to back. I'll get it raised, 10 millimeters and, put that collagen membrane in and everything heals really nicely. It takes about a year and a half to really start to see all of that kind of begin to ossify fully in. You can start seeing at about 6 months, you can really kind of start to see, okay, my sinus is clear. What are things we want to see on a post-operative basis? No OAC. On a post-operative basis, we want to see that the sinus is healing and that the sinus is clear and that there's not any rhinosinusitis or chronic sinusitis. What else? What other questions you guys got?
Well, I think the only thing that I have left on that one, and I'll leave it because I know we spent some time on it, but I guess I'm just curious about, so you're kind of making this, oculus of bone, right? It's like a window of bone that's getting crushed up into the sinus. I guess I'm just curious about how that heals. Like what kind of architecture do you see in follow-up? So you mentioned like a year before everything ossifies. Like what kind of healing are you expecting to see? And what does that look like?
The only thing that I want to see is that we'll kind of re-ossify a floor, right? We left the bone, and so then, eventually it will ossify by lifting it up, and not utilizing particulate graft.
Okay.
The cases where, again, so what I'm trying to do is I'm trying to use as much autogenous stuff as possible, right? I want the patient's blood. Mm-hmm. I don't want to put a bunch of dead cow bone in there, a bunch of dead human bone in there. I don't really want to do that. But, the sinus has such a healing potential. Anything we put to lift it up will turn into bone eventually. And so, even on zygomatics, when we do a nice channel along the the buccal alveolus there. I'll kind of lift up the membrane. I do not do particulate graft. I'll just put a little a piece of collar tape in there, and then a year later it ossifies, and you get a nice plug of bone all where that sinus was lifted.
Very nice. Very nice.
Yeah, I think it's a great technique to have in your back pocket for a case that maybe, like you said, you need a minimal amount of sinus lift, but because if you're lifting the sinus, like, so I had a case, and I know you saw this one, Clark, where the guy smiled and his sinuses were so far down, and my plan on that case was option one, big sinus lifts. And then coming back and attempting the case in that manner. But there's a lot of patients out there that smile, and they have that Kelly syndrome, they have that combination syndrome, but maybe it's only like 4 or 5 millimeters that are showing. And I think it's a great technique for someone like that wants to get it done in one surgery, maybe can't do the whole waiting 6 to 8 months for the sinus lift to heal, and then allowing it to get it done right away rather than waiting that long period of time.
Yeah. The one particular case, obviously this gentleman smiled really high, and you could, see the mucogingival junction bilaterally, and you could, he had gull wing lips. You could actually see probably 5 millimeters beyond the mucogingival junction. In addition, he had all of his teeth, and they were all just rotted down to the gum line. Mm-hmm. And so, my recommendation on a case like that is edentulate, get everything healed first. I wouldn't even do the sinus lifts. Like, this would be a ultra staged case.
Yeah.
Hey, we're going to take your teeth out. You're going to heal. We're going to make sure your sinuses heal. I believe that patient had sinus disease too, right?
Yeah, he did. He had really, really bad sinuses. That's what I did.
So he may
teeth out.
Yeah, teeth out, then maybe go get a fess, and then come back, and then get a sinus lift, and then come back, and then get your arch surgery, right?
Yeah.
So,
and that's what I did. I did took the teeth out, let those heal. He sent him to an ENT. He kept pushing off the fess. Came back into my office. The sinuses were a little bit clear, a little bit, but definitely not where they needed to be. And then what we ended up deciding was, he was like, I just don't want to do this anymore. So we put him in a dent on the top and fixed on the bottom. And honestly, that was kind of a relief for me, because that was like, I would have had to do a massive sinus lift. And then you're stuck in a situation, right, where you do a sinus lift that big and you fill it with, 10, 15 cc's of bone. And how long is it going to take for that bone to ossify? It's going to take a long, long time. And you go in there and cut everything down, and it's going to be mush. And I honestly wasn't confident that it would have healed the way that I wanted it to. And the patient didn't want to spend more than our traditional all on X fee. And it was a lot of surgery to do with unsure prognosis.
Right. Yeah. Well, but let's just assume that he wanted to do it. Obviously, your concern is right. Just because we put in bone into the sinus, we've all seen cases where, the bone just is mush, right? So then what do? Well, now you have a great zygo case, because you got the sinuses way out of the way, right? Mm-hmm. And so now you can go in, that is a great zygo case, because you're not having to worry about, okay, well, is there going to be a long-term OAC here? The sinuses are super high. All you got to worry about is just getting really dense remote anchorage into the zygoma. So it doesn't even matter if that bone becomes mush, which it may, because it is so large, but because you're gonna get remote anchorage. I was actually referred a case very similar to that several years ago. They squeezed in an a standard arch on a Patsy patient. Lo and behold, 3 implants fail. They go in, they add in a couple more implants. So the guy had his second surgery. They then said, well, things are getting really constricted. You're only on like 10 teeth. So let's go in and do bilateral sinus lifts. So he had his third surgery. It was bilateral sinus lifts. And then they waited for that to heal. And then they came back in and they popped in, like 4 implants into the sinus. And they all torqued to like 5 Newton centimeters. And these clinicians were like, oh my gosh. And the patient was just worn out. So they referred him to me. That they wanted me to just do it and actually just uncover him in hopes that the implants actually torqued or osseointegrated, but have the patient out sedated and ready to go to throw in zygos if they just backed out. And I mean, they backed out in a second, all 4 of them.
Of course.
And so, which is no big deal. We'll just, roll in and do the zygos like what we planned. And, the patient was very grateful. And I'm thankful for the patient because he got out of that cycle. Right. But again, just because we can sinus lift, doesn't mean that that's the answer to all of our problems for sure. So, if you're not wanting to commit to a case like that because you're afraid of mush bone after you do the sinus lift, that needs to be in your head. You need to think. You can't just think the sinus lift is going to solve your problems. But roll in and do a zygo, or have somebody come and do the zygo then, and then the patient can be a patsy, and it'll work great.
Agreed.
Yeah, no, that sounds good. So the next one that I want to get into is, for us, I mean, I think one of the ways that you've, Clark, influenced Soren and I, and also Caleb, and really our whole group is, converting us to the idea that just about every maxillary case can benefit from the use of pterygoids. And I think that you've shared some data. I think we actually talked about in an interview with Zelig about data you've collected on pterygoids that you've placed and the success that's come about that. And they were extremely impressive and really better than in standard implants, really. And so I was hoping you could share that as well. And then I do have a few, minor subtle questions about how we place our pterygoids and the ideal depth and multi-unit selection and things like that. So could you talk a little bit about your follow-up on your pterygoids?
Yeah. So, excuse me. Wilkerson put out an article in 2021, and it was a finite elemental analysis, blah blah blah, article, and it showed that by utilizing pterygoids, it took significant stress and strain off of the middle implant, which is your posterior tilted. Comparing that to a standard all-on-X arch without pterygoids. And so, we have data that shows, hey, we can reduce our stresses and strain on our middle implants and even on the pterygoid implants. When you look at the finite elemental analysis, there's very little stress and strain on those back pterygoids. So, granted, no cantilevers and reducing stress and strain is only one part, right? The other part of this is occlusion, and having bilateral simultaneous contacts and not having posterior excursive interferences. If you can do that, you're gonna save yourself a lot of trouble. So, I jumped in, dived head into the pterygoids. I started back. My first 6 pterygoid implants that I did were back in 2017, and utilized those for emergency cases where I had a posterior implant that failed, and I wanted some extra anchorage. And so Vishy Broman asked me to compile my pterygoid data, and so the data that I have is actually already behind. It's probably 2 months behind, but as of probably the middle of May, I had placed 974 pterygoid implants. So I think Vishy said that out of he's collecting all this data. Vishy has data on 8,000 pterygoid implants.
Wow.
And the interesting thing that he said was that Dr. Clark Damon and Dan Holtzclaw are the number 1 and 2 guys in the USA for pterygoids.
Oh,
so I thought that
amazing.
was really kind of cool.
Congrats, yeah. And I assume you've hit 1,000 by now too.
Yeah,
so.
yeah. So I was gonna say
so
that.
we're at 1,000 by now, but
Fantastic.
And I got lazy. I didn't even look at my 2018 or 2019 data. So maybe there's some pterygoids in that data as well. But printing out a pano and re-going over all of your cases is actually a daunting feat.
I can't imagine.
So let's see. So the interesting thing here is just kind of the ramp up. I started placing them in, like I said, it's 2017 with 6 pterygoids in function, and I have 8-year follow-up on all of those and 0 failures. In 2020, I had, from 2020 to now, 0 failures. What's in front of me, I don't have the number of pterygoids I placed in 2020. But in 2021, I placed 70 pterygoids. But in 2021, I placed 70. 22, I placed 256. Right, so you can kind of start seeing we're really
There's a ramp up
kind
there.
of ramping up here.
Yeah.
23, 238, 24, 260, and currently in 25. I have 144, but that's through May, so it's probably more like 175 by now. So total failures 4, 1, 2, 3, 4 out of the 974.
Wow.
I want to spend more time in the data that I have and look at the number of I was not shy about if I had a pterygoid that was only at 20 Newton centimeters, I would just carefully put a cover screw on it and we'd bury it. If I felt that it just had stability, just not torque, right? So I want to go through and find, okay, well, out of the 974, how many were loaded? I mean, just off of the cuff, I would say that most were loaded. Maybe I could probably count, maybe to 20 that I didn't load 20, and we would roll back in and uncover and always be able to place an abutment.
So if you're putting a pterygoid in and you got like under 20, maybe like a 10, did you ever leave those or did you remove those at the time?
My dad is not that specific.
Yeah,
Sure.
Because I've been, back and forth on some of those where I'm if I'm fairly confident that I'm in the right spot, and I think that's the biggest hurdle with pterygoids, right? You can't see them, you don't know for sure. But before I place any pterygoid, I always get my probe in there. I'm making sure that I have bone on all 4 walls. Making sure that I'm not through the lateral plate, or I think one of the biggest not complications but biggest issues with placement that I see are when people don't widen the apex enough and they're kind of doing a transsinus pterygoid and it hits that posterior sinus wall and just slides
Just rides it. Yeah,
correct.
I see that quite a bit. So if I know that I'm through that pterygoid to
through the pterygomaxillary junction.
Yes, through the junction
into the pillar.
Into the pillar. Then even at 10 Newton centimeters, I've put a cover screw on those, and I've had success doing that. I was just curious if you typically would remove those, or if you had a similar kind of thought process where if you were pretty confident in the right place, you'll give it a shot at least.
Yeah, I think if I'm confident now, the huge concern is just getting your cover screw on and making sure that you don't push it into the infratemporal fossa, right?
Yeah.
So, typically kind of my goal is, I would like for my, because I place them on the contra angle and I have it set to 30 and 30, 30 RPMs and 30 torque. I would like to hit 30 Newton centimeters of torque on my handpiece within and still have 5 or 6 millimeters of that of the implant sticking out, super crestal, right?
Yeah.
I basically will stop if I get like equal crestal. I'm just like, nope, we're gonna back this out, and I'm just gonna kind of reevaluate.
Mm-hmm.
And then two, to me, it depends on how important it is that we get the pterygoid back there, whether I'll leave it or not. Like let's just say it's a quad zygo case, because I've had one of these, a quad zygo case. I didn't have a pterygoid get super stable, but I was like, I've got to have this. So I left it, and it's in function today. It's been in function for 3 years. So I do think that there is some minor ossifying or minor osseointegration potential back there. I don't think it's a lot. And, I think most of the stability that we get is from the pyramidal process, and most of the stability is going to be primary. But that being said, I mean, I probably 30%, when it happens that I'm getting less than 45 Newton centimeters of torque, the first step is back it out and reorient, right? And reevaluate. Oftentimes, when you have not gone through that posterior sinus wall into the pterygomaxillary junction, because all of a sudden you're going to be saying, I don't think I drilled it at that angle, right? Because now all of a sudden you're like, man, this is a really superior angle, and I was a little more shallow. Well, that's when you're totally in the tuberosity. And the early data, from Linkow and Tulsani and those people was that the pterygoids they had about 62% success, and it was because actually a lot of them were more tuberosity implants. And Rodriguez et al. Said that the pyramidal process is about 13.5 millimeters, and that is within the palatine bone, 13.5 millimeters high. And so we have to get to that. So we have to go through the maxillary tuberosity to get there. And so what Rodriguez et al. Said, back in 2017, was that the minimal pterygoid implant length should be 15 millimeters, so that you can get there. And then that's obviously when we started seeing the pterygoid implant success really explode into the 90s. 90% off.
That 15 millimeters, do you think that is talking about if you don't reduce the tuberosity down? Because now a lot of people are doing reductions on the tuberosity, and I would imagine that would decrease that number a little bit.
Well, I mean, my standard, from the guy that's done 1,000 of them, my standard or my average length of pterygoid is 18.
Mm-hmm.
My preference is, again, you run into trouble if you're too anterior, right? You run into trouble if you're too anterior and medial, right? You run into trouble if you're too posterior and deep, and you run into trouble if you're too lateral. So I like to place my coronal entrance point in between the second and third molar. And, just from, geometry, because you're already back that far, typically 18 is what you need. And I'm also not looking, to take out the medial pterygoid plate. And I don't necessarily want it resting on the medial pterygoid plate either. It doesn't have to be all the way there. It doesn't have to brace against that. All too often I see clinicians post their axial cross sections of these x-rays. And I'm like, the tip of your implant is in black. It's in black air. You're in the nasal pharynx, right?
Yeah.
You're
saying you're going through too medial?
You've gone too medial and too deep, right?
Yeah.
Clinicians always ask, like, okay, I know where the pterygoid fossa is. And, on one side you have the lateral, on the left side you have the medial plate. Where do I need to be? And my answer to that is you get your stability in the pyramidal process. We're not getting our stability from the sphenoid bones. And so we don't need to be in the medial pterygoid plate. Now, I teach everybody, aim towards the medial pterygoid plate because you need to be medial, and that's the hamulus is a great landmark. That's where we want to be. But because we're not getting stability back there, I don't necessarily want a 22 length implant bracing against that medial plate. I can't feel that. I don't know if we're there or not, because we're blind. The other big thing so where do you need to be? Obviously, just view the lateral and the medial pterygoid plate as a field goal. As long as you're in between there, you're pretty good. Obviously, I want, it's kind of good, better, best, right? Like if you're on the lateral, if you're touching that lateral pterygoid plate, but you're still within the pillar, yeah, that's good. Better would be straight in between the uprights, right? Straight in between your medial and lateral plate. And best would be, hey, I aimed it and took and went straight, went into the pyramidal process, and I stopped right at that, kind of that bend where it turns around and it meets the fossa meets the pterygoid plate, or the medial pterygoid plate. That would be, great.
Because you have almost 100% bone in contact at that point.
You have lots of bone to implant contact. Now, we're not going to get any stability from the maxillary tuberosity bone. So that bone to implant contact there really doesn't count. But
that's something that really interests me about when we sleep a pterygoid, right? So, we don't expect there to be, much, if any, stability to come from the osseointegration of the tuberosity bone because it's mostly fat back there, right? But we're really just, let's say you go in between the uprights and you go right through the pyramidal process and you're into that fossa, how much bone have you actually passed through that has the opportunity to osseointegrate? It's amazing sometimes that we can actually sleep a pterygoid, and just that amount of bone osseointegrating is going to grant us that stability when we go and uncover and put a multi-unit on there. And I wonder, how, in terms of how successful you can be in sleeping a pterygoid and letting it cook for a while, how much of a difference it makes if you just went kind of transversely straight through into the fossa versus if you, engage the medial plate, because obviously, or at least I would think that with more bone implant contact down the medial wing, you're going to have a better chance of getting that secondary stability down the road. Whereas if you just kind of cross right into the fossa, there's not a whole lot of bone that's really going to heal around that implant and mature. But all that being said, very similar to your situations where you've slept pterygoids. In times where I've done that, it's been, as long as I'm in a relatively good position, it's been fairly successful. I kind of feel like on the rare occasion that you don't achieve torque, I kind of do 3 different things. And I think it just kind of depends on how I'm feeling on the day. Right. Yeah.
I may back it out, and we may be like, all right, sweetheart, you got 5 implants. That's all you're getting. See ya. Right.
Yeah.
I may sleep it, or, I may say, hey, we'll see you back in 3 to 4 months and we'll reattempt it because I want you to have a pterygoid. So yeah. I really think it all depends, on that. I've been happy on the cases where we didn't nail the pterygoid and we nailed one on the contralateral side, I've been happy, not doing an extra surgery and then just finalizing them and just being like, that's what you get.
Yeah.
And I've been frustrated on the ones where I've kind of gone the extra mile, where it's like, okay, we'll see you back in 3 to 4 months. We'll add the pterygoid, because then it just kind of, now their tooth process just extended,
Yeah.
So it's always kind of, half of one, half of another, and some days you get it right, some days you don't, but you just got to love yourself.
That's right. That's good.